Assalamu alaikum. We'll start today's session. Our day is long clinical consultation. We have Miss Hoda, 32 years, with complaint of fits. We'll start now after sharing the timer. Okay, ready? You can see the timer.
The timer is clear, yes.
Yeah,
Yes.
Dr. Mahmoud, ready? Yeah, okay.
Yes, yes.
Here you go.
Hello, my name is Dr. Hussein, one of the medical doctor in clinic today. I'm talking to Miss Huda, 32 years old.
Yes, I am doctor.
Miss Huda, I'm here today with you to discuss some issue related to your health condition and examine you and address your concern. Is that okay?
Okay, doctor.
Miss Huda, it came to my knowledge that you have been troubled by body shaking. Can you tell me more about that?
1 minute. Yes, doctor. I have this body shakes since this morning. I have attack since morning, doctor.
I'm so sorry for that. Did it started this first time to suffer from this body shakiness?
This second time, actually, doctor.
This second time. When the first time attack?
Yesterday.
Yesterday. Do you have any attack before this yesterday?
No.
Mhm. Okay. What do you mean by body shakiness exactly, Ms. Huda?
This body shakiness, doctor, in all my body.
Oh my God. I'm so
Like
sorry for what
jerky
happened to you.
movement, doctor.
Mhm. Do you lose your consciousness?
Yes.
I'm so sorry for that. Before this attack and previous attack, do you have any abnormal sensation or strange taste in your mouth?
No.
See any flashes or bright lights?
No.
Mhm. Any hand shaking before this attacks?
No. No, doctor.
Do you feel hungry before this?
No.
Any hand sweating?
No.
Racing heartbeats?
No.
Mhm. Also, do you lost your consciousness? Am I right?
Yes.
Any of witnesses person told you that you shake your hands and legs?
Yes. My
Do you
sister.
told you that okay? Your eyes goes up,
Yes.
drawing saliva
Yes.
from your mouth?
Yes.
Mhm. Do you bit your tongue?
Yes. Unfortunately.
I'm so sorry for this question. Do you lost your water control?
Yes, doctor.
Mhm. Did you get trauma from this body shakiness?
Yes.
How this resolve it?
This fits, you mean, when I came to hospital.
Again?
When I came to hospital, they gave me IV fluids and gave me medication.
Mhm.
Mhm.
Okay.
Yesterday they said for me that I need to be admitted, but I escaped from the hospital, and today I came again.
Mhm. What did you doing before this fits?
Before this fit, I was in my usual daily activities. at my home, doctor.
At home? No walking, no running at the times?
No.
مهم. معلش يا دكتور بس sorry زي ايكو.
Disappear now. Resume.
Okay. Miss Huda, any trauma to your head before?
No.
Any high body temperature?
No.
Any headache?
No.
Neck pain?
No.
Any lump or bump elsewhere in your body?
No.
Any change in your weight?
No.
Night sweating?
No.
Any bleeding elsewhere in your body?
No.
Show me your medication list.
I'm using phenytoin, doctor.
Since when this phenytoin?
Since more than 2 years.
2 years. For what?
Because I diagnosed before that I have a condition called epilepsy.
Epilepsy. Okay. Any recent change in this phenytoin?
No, doctor. And since 2 years, I did not get any fit.
Are you completely adherent to this phenytoin?
Yes.
Okay. Any other medication you used now?
Yes, doctor. I'm using insulin also.
Insulin for diabetes, for high blood sugar.
Yes.
Dose?
It's 10, 10, 10.
Since when use this insulin?
Since more than 15 years, doctor.
15 years. Any recent change in this insulin dose?
No.
Your high blood sugar, is it controlled?
Sometimes, doctor. Yes. I'm trying to do
Show
that.
me last 3 months test called hemoglobin A1C.
I don't remember it, but it was high.
You have regular follow-up.
Yes.
Practicing exercise regularly.
No, not regular.
What about your diet? Is it contain sugar?
Yes. To be honest with you, yes.
Okay. Any other medication than this insulin and phenytoin?
No.
Do you stop any medication recently?
No.
Do you have an allergy to any medication?
No.
Any past medical history I should be aware of other than this epilepsy and high blood sugar?
No.
Any surgical operation?
No.
Do you have any joint pain?
No.
Any skin change?
No.
Okay. Miss Mona, do you have any weakness,
No.
unsteadiness?
No.
Okay. Any vision problem?
No.
Speech difficulty?
No.
Chest pain?
No.
Difficulty breathing?
No.
Noisy chest?
No.
Difficulty swallowing?
No.
Tummy pain?
No.
Tummy distension?
No.
Change in your bowel habits?
No.
Any loose motion?
No.
Okay. What about your water work? amount
My water work amount, sometimes I feel that it's increasing amount.
increase?
Mhm.
Frequency?
It increasing frequency, yes, also an amount, yes.
Si-
But
Since when?
since like 10 days, yes. But when I check my blood sugar, I noticed that my blood sugar is high.
Mhm. I'm so sorry for that. Okay. Any frothy water work?
No,
Puffiness around your eyes?
no,
Mhm. Any sensation change elsewhere in your body?
no.
Dizziness
I,
when change your position from sitting?
I just have a needles, pins needles sensation in my fingers of my hand.
Sure, sorry for that, Ms. Huda. Any dizziness when change your position from sitting to standing?
Yes, sometimes.
Any weather preference?
No,
Mhm. Okay. Miss Huda, okay. Do you notice your eyes became pale than usual, than before?
no,
Any yellowish discoloration of your eyeball?
no,
Mhm. Okay. Do you smoke?
no,
Drink alcohol?
no.
What's your job?
I'm not working nowadays, doctor.
Mm,
I'm searching for a
mm,
job. Mhm.
Are you driving?
Yes.
Miss Huda, we need from you to stop driving immediately until further assessment, okay?
Okay, doctor.
Okay. Miss, any high blood pressure?
High blood pressure? No,
Mhm.
doctor.
Any any high cholesterol?
No,
Any history of blood clot before?
no,
Mhm. Okay. Are you married, Miss Huda?
no, doctor. I'm single.
Mhm. Okay. Miss Huda, let me to examine you, okay?
Okay.
Mhm. Okay. Give me vitals.
All the vital normal.
Mhm. Okay. Uh, I would like to do check eyes, uh, Balar jaundice,
Buller and jaundice or negative.
fundoscopy.
Yes, there is the diabetic retinopathy.
There is retinopathy. Okay.
Mhm.
Mhm. Okay. And okay. Uh, in the neck, any lymph nodes palpable?
No,
Okay. I will do pronator drift,
negative
tone power, tone power reflexes, upper limb,
or negative.
coordination,
Negative.
sensation in upper limb.
Yes, the negative also. No
No
sensory loss.
gloves, no gloves.
No sensory loss. Yes.
Mhm. Lower limb, tone power reflexes.
طبعا هيكون في تعمل الكلام ده كله لكن
Mhm.
all negative.
Any sensation?
All negative also.
2 minutes remaining.
No. Okay. Okay, Miss Huda, what's your concern?
I want to know why I got this doctor.
I highly appreciate your concern, Miss Huda, from what you said to me and after examining you. Most likely this a recurrence of this epilepsy or yes, due to this, the reason behind this, also due to a high blood, uncontrolled high blood sugar, okay,
Mhm.
leading to losing this medication and lower its level in your blood. So you get this attack.
Okay, doctor, I didn't get you. I didn't get you. You mean that with this uncontrolled high blood pressure, how causes this?
High blood sugar uncontrolled, leading to increased amount and frequency of this loss of water work, increase the amount and frequency, leading to decreased level of this medication that you used phenytoin in your blood, leading to this these attacks.
Okay, doctor. Okay. Yes.
Do you have another concern?
No, doctor. Okay. خلاص كده هنا. Okay. I will start
Okay,
the
time is up.
examination.
Yes. Yeah.
Yeah.
Start.
Okay. What is your differential for the case?
Yes. This epilepsy due to a drug failure of this phenytoin. Also could be
Yes.
this encephalitis, but against that, no high blood pressure, no symptoms.
Yes. And also you explain something to the patient.
What?
You explain something to the patient. Yes.
Like what?
Okay. Okay. Continue the differential.
Yes. Also could be stroke, but against that, no symptoms related. This uncontrolled or failure of control of epilepsy. Yes.
Failure control ability. Okay. How you investigate for the patient?
Okay, we'll do base lab investigation in the form of full blood counts, renal function test, liver function test, electrolytes, and inflammatory markers. You would look in electrolytes for this could be hyponatremia, also one of the cause, can lead to failure of control. Also, I will do yes hemoglobin A1C, fasting blood sugar. Also, I will do brain CT to rule out other differential. Yes, that's all.
To rule out other like what institute?
If there is an infection,
Like infection.
it's like
Okay.
infection, yes, or bleeding.
Any other thing you want to add?
Investigation.
Yes. Okay. How you treat?
Okay, education and non-pharmacological education and counseling of the patient about her condition,
Yes.
and multidisciplinary team from neurologist, dietitian, and yes, dietitian and exercise trainer, and also specialized staff nurse. Admission of the patient, ABCD approach, and stop driving, pharmacological, treat the underlying cause of this medication failure, this control this diabetes that can lead to electrolyte disturbance and like hyponatremia or excessive loss of this phenytoin.
Yes. Okay. I finished the questions, Dr. Bassam.
Okay. You can ask him about other differential. He did the other differential, Dr. Mahmoud.
What?
Other differential.
Yes, could be hyponatremia.
Okay, the
pure
management,
uncontrolled.
full management plan, pharmacological.
Yes, admission.
Okay,
Yes, pharmacological. Yes, pharmacological. Uh, uh, Correct. The underlying cause of this, I think, this lead to drug failure. If
okay. If the patient came to you with seizure, yes, and you want to control the seizure, how you could start managing acute attack?
admission, ABCD approach.
Yes, excellent.
Yes, and
Then,
yes, control seizure by if currently has seizure. This uh, by this uh, diazepam.
okay,
Yes.
if the patient already on, he's selling or she's on phenytoin, would you like to do drug level? You did it in the investigation, did you?
Yes, yes, we need to do it. Yes,
Yeah, if
we need.
subtherapeutic, what do you think you can do?
Yes, treat underlying cause and increase the dose of this medication.
Yeah, you can think also to load the, for loading,
Load,
right?
loading the,
Yeah,
yes,
loading.
loading,
Yeah,
loading
loading
this
dose.
dose of, yes.
Yes, of phenytoin. Okay, thank you. Let's hear Dr. Awatif comment, then I will comment. Thank you, Dr. Abdul.
Thank you.
اوكي. آه بالنسبة للأناليسيس، أناليسيس كان كويس. بالنسبة للألفت، you covered المين issues كلها. حتى بالنسبة مثلا الانفكشن HUS like this you covered. بس شنو بس في البيشنت ده انت يعني البيشنت ده باشوفك illness. This patient I mean this has a basic illness of epilepsy. We didn't ask about the trigger of epilepsy. Yeah, 2 years on control. Any stresses, any noisy, any flashes. You ask it what was doing when the attacks happened. This can give you clue, but also you need to ask about something specifically like stresses, for example, like any signs of dehydration also. I mean any risk of dehydration. Um, and you catch it, this polyuria. It's good. Okay. Then in the differential, yes, in the concern, you you explain to the patient that this fit is related to this polyuria, but in the differential you didn't mention this. In the differential you mentioned that this epilepsy due to drug failure.
Yes, I mentioned to patient in this drug failure could be due to this uncontrolled high blood pressure, sugar lead to this excess loss of or passing more water.
Mhm. This بالذات in Irish, they are sensitive to this to يعني how to say the differential. I mean this is we cannot say this is drug failure because 2 years he was controlled on this medication. If this due to polyuria, you mean due to dehydration, you can say epilepsy triggered by dehydration or by due to polyuria. You can say it like this, due to uncontrolled diabetes. Encephalitis, um, no any signs going with this because there is no any high temperature, but we can keep it in the differential in the bottom of the list. Um, yes, stroke also can be electrolyte disturbance. Yes, this is good. Can be electrolyte disturbance. This epilepsy may be due to dehydration and also can be due to electrolyte disturbance, can be also. And then the other differential. Yes. And the infection will be at the bottom. Um, Regarding the investigation, yes, basic diabetes screen. You said that brain CT to exclude the infection and the bleeding. And I don't think we can say like this, infection and bleeding, because no signs going with infection, but maybe bleeding. But also there's no signs going with the bleeding because the patient has no any headache. But we can exclude it. But although there is nothing going with this, if anyone then can comment on this point. Regarding the treatment, yes, you said the treatment very well. Yes, I have no comment on that. خلاص كده.
Okay, thank you, Dr. Awad. Well done, Dr. Mahmoud. You covered the topic well. Actually, also, I didn't reach to the cause, but yeah, it's one of the possible causes to be like
Yes,
dehydration.
it is for the
Although,
friendship. Mm.
yes, for the dementia. But there will be another clue. You can say if you have changed any dose or added any medication recently, or did you change your behavior recently? Did you do something which is new recently
Okay,
in
Dr.
your life?
Nasser, can I ask something? Yes, there is
Yeah,
other
sure.
difference. I forgot. Yes, yes. This patient has long time diabetes, more than 15 years, and bad control, and also he has neuropathy. He has some signs of complications, some complications of the diabetes. And also she didn't ask about the eye vision inside the history. So can be autonomic neuropathy, can be an awareness also. Yes, we didn't ask about the
But no, he asked about vision. I wrote. He asked about any
ask
vision
about
change
vision in
or
the history.
speech.
Okay, yes.
Yeah. He asked about this vision and the speech and
Okay.
balance. Yeah, I'm writing here.
Yes, because
But still,
he kept in the examination, he got a diabetic retinopathy. It is just one of the differentials. Can be hypoglycemia also. He asked it about the symptoms of hypoglycemia, I think, and was negative. So can be an awareness because patient
yeah,
also has both hypertension. Yes.
actually, what Dr. Mahmoud did was perfect because he covered all the possible causes of epilepsy or underlying cause of possible to be possible cause for this recurrence of the epilepsy. He did everything either by the history from the attacks. Let me comment. Yeah. So he started by onset course duration first or second. It was second. Then he got from that. He's already previous attack of epilepsy and the awareness it was lost. So it's clear for him and for all of us. It's an epilepsy attack. Why? The eyes rolled up and the drawing of saliva, biting the tongue, wetting herself, and also should be sorry for this question, as Dr. Mahmoud did. Then he screened for the CNS possible cause, which are headache, neck pain, neck stiffness, or weakness, balance, vision, speech, to rule out any central cause. Then the cardiovascular chest pain, chest short of breath, noise. By the way, he asked also for the hypoglycemia signs and symptoms, feeling hungry, shaking hands, palpitation, and sweating. This is very important. And he asked before the attack, did you feel any or did you see flash of light? Also, it's very important question. The chest, the GI screening system review, endocrine and genitourinary, and he found the patient is polyuric. So, yeah, you can think that dehydration, metabolic cause of electrolyte disturbance or some imbalance in the electrolyte. Joint pain, skin rash. Yes, everything was covered. And the travel, the family history, he didn't ask family history, by the way. I wrote here, but should ask because in such age and if there is skin rash, you might think about tuberous sclerosis. Medical history, you cover by asking the medication, history of medication, it was phenytoin. And the three question, as we know, did you increase the dose? Did you change the dose? Did you add any medication? Are you compliant? Did you change the dose? Are you compliant? And did you add any medication? The patient was compliant to her phenytoin for the last 2 years. She's also on insulin, compliant to the insulin, and the hemoglobin A1C was high. So uncontrolled diabetic could be the underlying cause of this patient. The surgery history and the allergy history, the job and smoking, alcohol, and driving was wise to ask the patient not to drive till be assessed later. The constitutional symptoms also he asked sweating, loss of weight, loss of appetite, and in yellowish the eye, yellowish or paler or pale eyes. You can also do in the examination. He did a quick examination because you will not find anything in such patient. She had the attack and she in between the attack she will be fine unless the patient is in the status epilepticus. He will be either post status or post epileptic state or post ictal. But in this patient was conscious, regain her fully conscious level. The examination, as I said, the vitals and the eye, he got retinopathy, panic for the lymph node, and you can add also neck stiffness. Still, you can suspect neck stiffness for meningitis, and you can offer clinic sign. Lymph node, CNS, pronator drift, clear, great to ask, and the upper limb tone power reflex, lower limb tone power reflex. I think he covered everything. The concern was perfect to answer and to address here. Like it's related to something maybe hidden, such as uncontrolled diabetes or poorly controlled diabetes, electron disturbance. But still, it's an epilepsy. No other reason for what she has. Only it's a clear epilepsy. The differential epilepsy due to either a drug problem. You can add interaction if the patient is taking some other medication. And you can ask also for over-counter medication. You didn't ask for any other medication you are taking, especially over-counter medication. You can add because if you ask for medical medication history, she might not tell you, I'm taking, for example, NSAID. You should ask her, are you taking any over-counter medication? And herbal also, you can ask. But actually, the case is very difficult. And what you did is perfect because you cover all possible question you can ask and you examine perfect because it's related to CNS. So for me, as I said, drug or the failure of the drug, as you said, or epilepsy due to uncompliance to the medication, or recurrence of the epilepsy. Then metabolic disturbance, either hypo, what cause any cause of hypo, or the other central cause. So again, the differential recurrence of the epilepsy or interaction of the drug or metabolic or uncontrolled diabetes. This is my comment. If someone want to add any question, any comment. The management for the epilepsy, as Dr. Mahmoud said, always if you have any topic in the exam, and the patient might present with this disease in acute attack, you should start ABCD approach. Any topic like asthma. If a patient came in between asthma and he's fine now or stable, but you should still to the examiner in acute attack, I should start ABCD approach. COPD, epilepsy, one of this topic. Sepsis, hypotension, any topic, my MS, SLE, any patient come to you in between attack and he's diagnosed or suspected to be having disease with relapse, you should start saying in acute attack, I should do 1, 2, 3. And first, of course, first of all, you will admit the patient, then ABCD approach. Then in between attack or in the acute or the chronic uh, management, you will tell what you will do as a pharmacological and pharmacological. I think the case is clear now. Any question? Any comment?
Yes, I think
Yes, Dr. Ahmed, you can.
yes,
You want to add?
yes. Regarding this, you said that failure of treatment. What do you mean by failure of the treatment? Because the patient controlled for 2 years.
Sorry,
What we
I can't hear
what we
you.
mean? Uh, um, the voice is clear now.
Yeah, yeah, but so far.
Is- Hello.
Yes, I can hear you now. Clear. Yes.
Yes.
Yes. What's your question?
Regarding this, when we are saying failure of the treatment, what we mean by failure of the treatment, because the patient is controlled since 2 years. What we are
Yeah.
meaning by failure of treatment?
Let's. Yeah. Let's say the patient is taking some medication which is interacting with the phenytoin. Okay, as interaction, or patient is taking in wrong way. So failure of either intake or absorption like this, because the case is not clear to say this is the reason, this is the clear reason, no clear reason in this patient. As you said, it's for differential. So I can guess that the patient is having some intolerance to the medication. By any mean, either intake loss, decrease or not decrease, not taking in proper way, taking with another medication and there is interaction, or
Yes.
I don't think the phenytoin has any food interaction. Is there for phenytoin? I don't think it's not like warfarin, right?
Yes.
It's different. Yeah, this is what I mean. There is also other medication like for example, hypothyroidism and levothyroxine, and the patient is taking the medication with iron and calcium, and the patient came with you with hypoglycemia, sorry, hypothyroidism symptom and sign. So you can put this in the differential interaction to some medication or interaction or decrease absorption. So because it's not clear, because as you said, it's for differential. So I can put this to differential failure of the medication effect or incompliant. But if the patient saying no, I am compliant, I can't assume. But I can say she's taking with other medication which can lead to some interaction. I'm guessing. So it's for differential, Doctor
20 ساعة يا
Awad.
محمد.
Okay.
Okay.
Yes. Well done, Dr. Mahmoud, by the way. If any other comment or any other question,
Assalamu alaikum.
alaikum assalam.
Yes, my comment is if any patient non-epileptic with good compliance as this case for 2 years or more, so we have to exclude triggering factor like anything lowering the seizure threshold, like sleeping deprivation. And when he's asking about job and she's telling she's not working, I suggest him to ask about why she's not working. If there is any stress at work, like this, to exclude any stress or because she's not alcoholic. So we have to exclude other causes of epilepsy.
Excellent. Yes, yes.
It's,
I agree with you.
yeah, other
The-
thing that like when explaining to patient with chronic illness like diabetes, that sometimes we have to increase the dose of our medication or to add new medications with time. So this, I think, may be a possibility that sometimes we have to increase phenytoin dose or add any other medications if there is no any underlying cause for this seizure.
yeah, you remind us to ask about the follow-up for epilepsy itself. When was
Yes.
the last time you follow up your epilepsy with a neurology or nerve doctor? And you can ask as well for any check for the drug level recipe, because yes, as you said, you might need to increase the dose for
The dose.
phenytoin or any medication. Excellent. Yeah, I agree with this question, especially if you don't reach to the diagnosis. Dr. Awatif make it like vague and more difficult, and to let us know that there is possible hidden cause we can reach by screening the history more and more. And I think Dr. Mahmoud did it in the perfect way. Yes, thank you, Dr. Ryan, and thank you, Dr. Rabia. Are you there? You can add some neurology
I'm listening and
points.
you
Yes.
no, no, mashallah, you people commented very well. Failure of medication, Dr. Basam, is supposed to be like this. If the patient is compliant to medication and still not controlled, that is the failure of medication. And for example, if I start one patient on phenytoin and I've given the full dose of phenytoin and it's still not controlled, that means it's the failure of medication. And you have to make it the full dose to say it's a failure of medication. It's not about he's not compliant or is he missing his dose or maybe he added another medication. This is not failure of medication. Failure of medication means he's taking the full dose and still the fits are not controlled. So that is the failure of medication. Maybe she's taking oral contraceptive pills or something like a female. So maybe it's not said as failure of medication. Maybe it's another cause rather than failure of medication. So to say to failure of medication, it has to be full dose and not controlled seizures, okay? Otherwise, any other cause is not supposed to, you're not supposed to say failure of medication. You understand what I'm trying to say?
Yes, yes, I agree also with your yes. Respecting respecting your opinion, Dr. Rabia, you're right.
Yes,
One of the question here, very important, the OCPS. Are you taking
yes,
any pills or birth control pills?
yeah,
Even if she said I don't have partner, yes, we can consider this pills as some medication which can interact with any medication we are taking orally. Yes, I
yeah.
agree with you.
Any antibiotics, anything. And secondly, for me, I could not reach the diagnosis very well. Maybe I joined late, but I think maybe he had DKA, diabetic ketoacidosis, because sometimes they don't have the actual features, okay? And when you check the sugars are very high. So DKA can also provoke seizure. Okay, dehydration very less likely to provoke a seizure. Okay, this is my experience. It can be one of the triggers, but it's very less likely to provoke a seizure. Infections usually, metabolic disturbances, a lack of medication, non-compliance to medication can provoke a seizure, but dehydration is less likely to provoke a seizure. Even stress is less likely to provoke a seizure. Decreased sleep is likely to provoke a seizure. Any stress causing decreased sleep can provoke a seizure. Stress itself cannot provoke a seizure.
Excellent. Yes.
Hmm?
Yes, I thank you so much. Yes. I think, yes, your comment also explore to us more reasons and clarify to us that the epilepsy itself can be happen even the patient still on his dose, and this is what's called failure of medication. It
Yes,
means, yeah, the epilepsy itself need to be either adjusted the dose or adding another medication.
true.
So this is one of the point of the epilepsy. Although the patient will be compliant till on his medication till the moment, but still with the growing, you mean, while getting older, either the seizure will be controlled by this medication or to be not controlled in this medication and to consider adding medication. Is it true?
Yes, true, true. Because sometimes it's controlled, but with time it can be
Yeah,
uncontrolled, and you have to add another medication.
excellent. Yeah, yeah, understood. Yeah, thank you, Mr. Rafi. Thank you so much. Okay, any question? I think the case now more clear after Dr. Rabia explanation. Any question, any comments before going to the next scenario? Dr. Mahmoud, you can write your scenario until asking for other comments. Anyone to anyone to want to ask? Let's move. Second scenario. Dr. Mahmoud, write the scenario, please.
Yes, in chat box.
Okay, I'll bring it. Mr. John, 30 years, complain of double vision. So again, neurology case. Yeah. I like this type of practice to be in the same branch every time. Dr. Rawatib, be ready? 2 minutes, we'll start. Ready, Dr. Rawatib?
Yes, doctor. Yes. The voice is clear, Dr.
Yeah, I will
Basim?
show the timer, then you can start. Yes, clear now.
Okay.
Mahmoud, ready?
Yes.
Here you go.
Hello,
Hello.
I am Dr. Ahmed, the senior house officer in this clinic today. Can I confirm that you are Mr. John, 30 years old?
Yes, Doctor, I am.
We are here to discuss issues related to your medical condition. Is it okay with you?
Yes, sure, Doctor.
It came to my knowledge that you have problems in your vision. Can you tell me more about this?
Yes, Doctor, you are right. I suffered from this double vision for last 3 months. Yes.
I'm really sorry for that. Till now, you have this the double vision.
Yes.
Okay. Since you started this problem, is it continuous or is it on and off?
Continuous, Doctor.
All the day you have this double vision?
All the time I have this condition, Doctor.
I'm really sorry for that. Okay. Is it this double vision? Is it more at morning or is it more at night?
Not related to specific time on the day, Doctor, actually, all the times.
Beside that, you have any change, any problems in your vision?
No, my
Any
vision
blurring vision,
clear
I
is
mean?
no.
Yes. Any dropping of your eyelids?
Yes, Doctor.
Since when?
Since same duration, doctor, in this last 3 months.
Since same duration, this is the dropping of the eyelids increasing during a certain time during the day.
No,
Beside that, you have any redness in your eyes.
no,
This double vision, is it more when with eye movement in certain directions?
no,
Any itchiness in your eyes,
no,
pain in your eyes,
no,
dryness sensation,
no,
any tearing?
no.
This dropping of the eyelids, is it at one eye or it's in both eyes?
I can't to detect this, doctor, but when I see object, I see two image for one object.
I mean the dropping of the eyelids. Is it in
Yes,
one eye or both eyes?
no, both eyes, doctor.
Beside that, you have any headache?
No.
Any weakness anywhere?
Yes, I have weaknesses
Where is the site of the weakness?
in my legs.
In your legs. In the near part or the far part of your leg?
Far part.
Far part. In your hands also, you have weakness?
Yes, I little bit. Yes,
Where is the site of the weakness in your hands?
in my arm, doctor. Forearm.
You feel that your arms is stiffy or floppy?
I'm not sure, doctor.
You said that you lost your hair?
No,
You since when you have this? You said that since 3 months. You feel this weakness or this any similar problem before when you was young, for example, or a teenager? You are a teenager?
do you mean this weakness?
Yes,
In this last year?
in the last year.
Mm.
Okay. Um, do you have any heart problem? History of heart problem?
No,
Awareness of heartbeats?
no,
Pain in your chest?
no,
Any swelling in your legs?
no,
Or breathing difficulty?
no,
Any past medical illness I should be aware of?
no, doctor.
History of high, you have any history of high blood sugar
No,
or high blood pressure?
no.
I want to ask you privacy questions. Are you sexually active?
Yes, doctor.
You have any puppies in intimate relationship?
Yes,
I'm really sorry for that. Since when you have these problems?
this last 2 years.
Last 2 years. Okay. Any family history of similar problem?
This double vision, no.
Yes. Or any family history at all?
Yes, my brother has heart problem. Yes,
Your brother has heart problem. Since when? At which age he got this heart problem? I mean,
I think at 40.
when he was 40 years. What is the heart problem he has exactly?
I don't know, doctor.
Okay. Any other family history?
No, doctor.
What medication you are on?
I didn't use any medication, doctor.
Any allergy to any medication?
No,
Any over-the-counter medicine you are taking?
no,
I'm really sorry to ask you this question. Um, do you have any history of smoking?
no,
Do you drink a lot of alcohol?
No.
Okay. Um, do you have any weakness or difficulty when you combine your hair?
I'm not sure, doctor.
Any you feel that you are unsteady when you are walking?
No.
Any change the shape of walking?
No.
Okay. Do you have any history of loose motion
No.
or tummy pain?
No.
Any difficulty of swallowing?
No.
Mm-hmm. Do you have any bleeding anywhere from body?
No, doctor.
Any change in water work amount,
No.
color,
No.
or frequency?
No.
Okay. I need to examine you, Mr. John.
Okay, sure.
Um, I want the vitals of the patient.
Normal.
Normal. Yes. Then I will check the eyes for the ptosis. Is it bilateral,
Yes,
complete, or partial?
yes, partial ptosis.
Okay. Then I will do the H-shape movement. If you feel any double vision or pain, or can you tell me? And also, I will notice for any nystagmus.
There is double vision, yes.
Double vision and nystagmus.
No.
Okay. Then I will check the visual acuity for the patient.
Normal.
Then I want any features going with myositis atrophy, like balding of the of head,
Yes. Present.
any wasting of the facial muscles.
Yes, present.
Um, okay, then I will check the grip sign.
Positive.
Any wasting in the distal part.
No.
I will check the chest. Firstly, I want to check the pulse to see if there is any abnormality by my
Like
hands.
what? Like what?
Like any missed beats, for example, or bradycardia.
Rhythm normal.
Yes. Then I will check for any murmur in the heart pulse. That's
Negative.
all. Yes. Okay. What is your concern, Mr. John?
Yes, doctor. Why I have this problem?
From what you said to me after examining you, most likely you have condition called myotonic dystrophy. Medical term for medical condition, which there is um, affection of the muscles in some part of the body, causing like in your case, like the muscles of your eyelids. Sometimes it can affect the muscles of the swallowing and hands also, causing the symptoms that you have. And this actually is one of the conditions that can run in the family. What we need to do for you, we need to put you under follow-up after doing some blood tests and some special tests we need to do for you. After confirming the diagnosis, we will put you under follow-up of the joint doctor and yes, joint doctor and specialized nurse. They will put for you the plan of management that you in need. And also, we will involve with us urology doctor who can provide you with help regarding the problems with intimate relationship. Do you have any other concern?
No, thank you, doctor.
Okay.
You're done, Dr. Arif? Sorry, it was an internet problem, so the timer was reset again from zero. You have still 3 minutes almost. Anyway, if you finish, you can go to the exam time.
I finished. Yes.
Mhm. You can start.
Yeah, I
Yes.
took 15 minutes. Okay, come on.
Yes. Present your case.
Yes, this patient, young male, came with the dropping of the eyelids and came with double vision and ptosis. He has problems with fertility. He has family history of heart problem at young age. On examination, he has features grown with myotonitis atrophy in form of balding of the head, ptosis, and diplopia on HHF movement test. He has myotonic face and positive grip positive grip sign. Yes.
What's your differential?
My differential can be myotonic atrophy, can be also
What again?
myotonic atrophy type 2,
Okay.
and also can be myasthenia gravis. Again, is that the um, that the symptoms are permanent during all the 3 months, and also there is no proximal myopathy going with this. Can be also third nerve palsy. Again, is that I did not check for the pupil, but it can be differential.
Mm-hmm.
Can be also Miller Fisher. Again, is that no weakness in the no pulpar involvement also. Yes.
Okay. What's your investigation?
Apart from basic investigation, I will do 1 minute. Okay, apart from basic investigation, I will do investigation. I will do genetic test. I will do investigation for to search for complication, diabetic screen, and also cardiac workup, ECG, ECG only. Yes, ECG, and also I will refer the patient to the urology and ophthalmologist, urologist and ophthalmologist.
Okay, treatment.
I will counsel the patient about the condition. I will send also the patient from multidisciplinary team include genetic counseling team, ophthalmologist, urologist, and rheumatologist, specialized nurse, occupational health worker, and specialized nurse. Regarding the definitive treatment, no definitive treatment for myotonic atrophy. It's also a treatment of the complication. So supportive treatment.
Like what?
A treatment of the complication if there is. Regarding the diplopia, I don't know.
Mm-hmm.
Yes.
Anything other?
No.
You want to add it?
No.
Okay, thank you.
Okay. No specific treatment here, Dr. Mawati?
Yes, no specific treatment. It's also treatment of the complication. Just genetic counseling.
Yes, excellent. You can add this in the non-pharmacological genetic counseling
Yes, I
or
said it. Yes.
the condition. Excellent. Okay, Dr. Mahmoud, you can comment. Then I
Okay,
will.
I will start my comment. She
Yes.
did well. Okay, here's a main complaint, double vision. We need to ask from start, what do you mean by double visions? After
Yes.
that, yes, after that, second question, ask the patient if he closed one eye, this double vision disappear, to determine that is it monoocular or biocular. Okay. Differential diagnosis she covered is myasthenia gravis, Graves disease. Okay, and also uh, multiple sclerosis. Okay. Uh, in the family history, we need to ask from weakness, no double vision. If any weakness in the family, in any weakness, disease in the family, or any disease that causing weakness. Okay. In the social, we need to ask from driving, because patient has double vision. This is important. Regarding investigation, examination, sorry, we need also to examine lower limb. Also, patient complaining of weakness in lower limb. Okay. Also, we need to check also sensation to be sure this myopathy or motor sensory motor neuropathy. Okay. Regarding investigation, we need to do nerve conduction study, EMG, is a genetic test. ECG also we can add echo, and this fasting blood sugar, she mentioned that for diabetes screening and hemoglobin A1C. Yes. Also here it's important to involve a cardiologist, because the most important complication here is heart block and cardiomyopathy. In examination, important to examine rate. The rate very important, because this patient suffers from, as a complication, heart block, may get bradycardia. Okay. Also, yes, that is all. Thank you.
Yeah, thank you, Dr. Mahmoud. Well done, Dr. Awatif. But I will give you some comments for the exam purpose. Apart from this, you did great. Actually, you reached diagnosis, you did target examination, and the differential was perfect. Let's start for a comment from the beginning. Onset course duration, 3 months, and the duration and the onset was continuous all the day. You can specify question for the evening. Roll out myasthenia gravis. It's not the case, I know, but you should show the examiner that you are asking about myasthenia gravis by name, because this is one of the most important differential distinction. In this case, myasthenia gravis could be the cause. I know that you rule it out by finding the timing for the weakness and the double vision, but still you didn't specify the question. Or did you feel that at evening the symptoms getting worse? It's very important just to roll out myasthenia gravis to the examiner. It's a matter of showing the examiner that you are asking for the differential, because he might ask you, did you ask about evening weakness or this? You will say, doctor, I asked him and he said all the time. Okay, maybe the patient feeling that it's all the time, but you should ask him particular question Do you have these symptoms, especially or more worse at the evening time? So by this question, you showed the examiner that I asked for myasthenia gravis itself as a cause. Okay, this is first yeah, point related. In this complaint, I agree to ask system review and onset consideration and so on, but better to specify differential or try it differential in your paper and to ask every differential by one question. You troll out and troll in. For example, you put MS, multiple sclerosis, very important one as well. You can ask the question, specific question for multiple sclerosis. What is it? Do you feel the symptoms worse with the hot shower or with the hot weather? So you show the examiner again that you asked about MS by name. Okay, so this is question four. What other graves? Do you have any other preference? Yeah, you got the case, but you didn't rule out others. Still the other possible. You didn't ask about endocrine at all. So still grave is one of the possible and you didn't rule it out. Maybe there is association or maybe you, and
But
although
Griffiths has no any doses.
yes,
Am I right?
it will not be ptosis, it will be exophthalmos, yes. I agree, but I mean that to show the examiner that you are asking for all possible cause
You're
of your
yes, I am
complaint.
thinking about it. Yes, yes, you're right.
Yeah, write the complaint, then write the differential you might ask by one single question you can roll it out and to show the examiner that you are asking about it. It's a matter how to roll out the possible differential. Okay, this is the second differential. The third, myasthenia dystrophica. Yes, already this is our case. Myasthenia gravis, multiple sclerosis. I think yeah, these are the four main differential. There is other differential like third nerve palsy, Horner syndrome, but it's not common as what I mentioned: multiple sclerosis, myasthenia gravis, myasthenia dystrophica, and the last one, Graves' disease. Okay, let's go to the system view. I have some internet problem and connection problem. I don't know. You ask about cardiovascular, any chest pain, any awareness, because it's important in this patient if he has heart arrhythmia or bradycardia. The
Yes, I
chest short
think
of,
so.
you ask because I had some lost connection. The
Yes,
chest
yes,
short of breath,
yes,
very
yes.
important, short of breath. Why? Myasthenia gravis also can present with this short of breath at the evening time. Okay, so you ask both. And the GI, as you said, any change of the bowel motion, genitourinary. Why important here, genitourinary, Dr. Rawat? Why urinary symptoms here important? By one question, you can roll out the complication.
Because I asked it about any history of high blood sugar, he denied.
Excellent.
So I
Yeah,
was
excellent. Yeah, this is my question. So throw out association of diabetes because diabetic is one of the differential, and you can catch it from the so it's a matter of showing the examiner that you are asking about every single point. This one is one of the complication. I asked about diabetes in the history. How? By asking polyuria and are you feeling thirsty? That's it. So you specify a question for the complication and you showed the examiner and he will be impressed by your questions before going to the examination. And the examination also was target. Okay, the joint, the skin rash, I'm not sure if you ask, I didn't also hear. Maybe there's connection and constitutional symptoms. I didn't hear you ask about all of them. Hypogonadism. Okay, let's read out the complication after the comment. Constitutional symptoms, loss of appetite, loss of weight, and so on. Although no any alarming in this patient like association of cancer, but just for screening. Family history, very important, and you catch there is brother history of, and good question also, you ask any family history of other condition, not only weakness, any vision, any other condition, any medical illness in your family. If you're still suspecting familial condition or genetic condition such myotonia or such case. Travel history, medical history, allergy, over-counter, surgical, you can add also. You didn't ask for surgical because maybe patient diagnosed with heart block and he put pacemaker and you miss the point of pacemaker by not asking about the surgery. So this is one of the also questions you didn't ask, the surgery. Good question. Also, the intimacy, your intimate relation. You have any problem? Yes, and he told you there is the partner and very important question in the occupational you didn't ask because I told you there is a package of occupational. You ask for the job, smoking, alcohol, and you miss the driving, and it's fatal question in this patient. Patient is double vision, complaining of double vision. If you didn't show the exam that I for the welfare, I ask him about driving. He will minus you definitely. Driving in any eye vision or any vision complaint is crucial and maybe fatal for you. So try to put as package as I said. I don't know the job you ask or no. It's important as well, but I don't know if you ask, and I don't know what is the job of the patient. So maybe you didn't ask because I'm not remembering the job of the patient. Okay, the examination. You ask for the vitals and the pulse particularly. Yes, it's important to ask about the pulse, as Dr. Mahmoud. Even you can ask how is the character or the pulse rate. But I think Dr. Mahmoud, when she said what the pulse, so what she mean what the pulse, either brady or tachy or whatever. Okay, then the eye examination, full eye examination, afro as a mnemonic, A for acuity, F for field, R for reflexes, O for ophthalmoscopy. Remember this mnemonic, afro, A for acuity. So you'll just start the acuity, cover your eyes. You see how many finger? Okay. Yes, three, four, five. This is full eye examination, but it's not. If you don't have time, go to the target. Its shape in this patient. If you don't have time, what's your question? You will ask about the double vision, its shape, and the lid examination. That's it. But if you have time, show the examiner that you know how to examine the eye in details. Acuity, then the fields, cover your eye. Can you see the movement of my finger? But if in this patient, I think no field affection. Then the reflexes, pupil reflex, both sides. You might have surgical, or sorry, third nerve palsy, one of the differential as well, and its shape. Then the last thing, ophthalmoscope or fundoscopy. Nystagmus, you ask also. The face, it's target question for the character or criteria of myotonia dystrophica, temporal baldness, and haggard face. We don't say haggard in the exam, and weakness of the facial muscle. Then the hand examination also important in this patient. True hand examination for myotonia. Grip myotonia, hold my finger, and ask him to release. He will take time to release. Okay, this is grip myotonia. The other test is percussion myotonia. You percuss over the at the base of the thumb, percuss, and the hand will be having myotonia or the muscle will be contracted. Okay, let's go to as Dr. Mahmoud said, you can do also examination for the sensation. It's very important if there is association of diabetes to rule out any sensory affection. Then if you finish the concern, the investigation, I will ask you, Dr. Atif, a question. All investigation, okay, you did the target investigation, but I will advise you, don't tell the target and the diagnostic test and ignore the others. You said, yes, I will do all investigation and for the diagnosis genetic testing. It's good, okay, to say that, but you will have more free time for other question. You finish your exam time 1 minute before. I mean examiner time 1 minute before the end. Why? Because you said I will do all investigation, including the genetic testing. I will do only ECG. Why only ECG? Why you don't want to do echo?
Because no need.
That's why Dr. Who said no need?
Because I need from the ECG to see if there is any cardiac block. No need for echo to check this.
Okay, if there is diabetic, for example, okay, diabetic complication, macrovascular complication, coronary artery disease, and the patient will have cardiomyopathy, ischemic cardiomyopathy, you will diagnose it by
Yes,
ECG?
no,
Do
but the
okay,
patient
okay,
has no
okay.
any
Don't say
high.
only. Okay, you
Yes.
can say ECG. Okay, but you will say only. He will say, yeah, why? You are cardiologist. Do you think the
Uh-huh.
ECG enough?
Yes.
Okay, do what you want to do, but don't say only. You mean that you don't want to do anything else? For what? And the echo is non-invasive test, and it's just scan. I don't know why you don't want to do echo. Okay, so the complication is still possible. You can do echo. Anyway, don't say only, okay? And
Okay.
start the investigation by general investigation, basic baseline, especially the patient is if not diagnosed before. Basic baseline investigation, CBC, chemistry, urea, kidney function, liver function, coagulation profile. Why not? Because the patient maybe first admission and he will do this test to be in his file as baseline tests. Do it. Don't tell me it's useless. No, maybe as you said, there is a hemoglobin, or sorry, there is diabetes. There is some electrolyte disturbance due to his diabetes. There is some renal nephropathy. You might have high creatinine, so you will not do creatinine. Do it. And you will also utilize your time. Be smart while telling the examiner what to do. Because if you finish early your investigation and your management, he will ask you more question deep and in details for other differential, for other management, for other pharmacological, and you'll be in trouble. Why? Because you didn't utilize your time well. So investigation start by CBC investigation, as I said. Then you can say specific test for myotonia dystrophica, which are genetic testing, for example. What else I will do also screening for the complication. What are they? I will do hemoglobin A1C, I will do urine dip, and so on. Like kidney function, of course, this is baseline and basic. It's not specific. Any patient will come to you in the emergency, will do this test, right? So they are specific for complication or specific for the disease. For the disease, uh, uh, genetic testing. For the complication, hemoglobin A1C and urine dipstick. ACR, albumin creatinine ratio. You can do a lot of investigation which can utilize your time and consume your time without going to the details of management. Okay, try to be smart in your answers. Then let's go to the neurophysiological study, the EMG, as Dr. Mahmoud said, EMG and nerve conduction study, important in this patient, and ECG echo for the complication as a heart affection. Finally, I think no other test for myotonia apart from what we said. Then the management, as you said, non-pharmacological and pharmacological, counseling, education, and driving. You can repeat the advice for driving again here because this is one of the welfare points. You will show the examiner that still you are caring about your patient. I should ask him to inform the VLA and to stop driving. Alcohol, smoking, and other education. This is with non-pharmacological. Then the pharmacological, as you said, if you see no other medication for this, no specific medication. So what you will do for the remaining 2 minutes or 1.5 minutes? He will ask you other question for other disease, for other, uh, I don't know what he can ask you, but you have 1.5 minute, you will be squeezed for some difficult question. You don't know what are they because you finish early, no specific treatment in this patient. So what you will do? Don't put yourself in this trouble, okay? Try to utilize the 5 minutes, 1 minute for the presentation, 1 minute for the differential, 2 minutes now, 1 minute for the investigation, 3 minutes. The management for non-pharmacological, 1 minute, and the counseling and the multidisciplinary team, and pharmacological, for example, And the pharmacological will be 1 minute. For the other pharmacological management or the medication you can use either for the disease or for the complication. Okay? Be smart in your answers, then you will get the full mark. You already, I think you are doing everything perfect, but just try to be smart in your answers. The differential, okay, we mentioned the differential already. Any comment, any question?
Yes,
Hypogonadism,
Yes,
Dr.
Dr.
Basim.
Abdullah?
Yes.
Yes, yes.
yes, Dr. Basim, you are right. In examination, we need to check visual acuity because cataract one of the or some
Yes,
station.
excellent. Yes.
Also, you are right in echo. We need because the cardiomyopathy one of complete association.
Mm-hmm.
Also, in non-pharmacological in multidisciplinary team, we can add speech and language therapist.
Excellent. Yes, yes,
Yes. My question here, I can ask for blood sugar level as a part of
yes,
examination in this
yes.
case.
Yes, it's one of like vital chart. Give me the blood pressure, the blood pulse, temperature, and the reading for blood pressure and the reading for blood sugar. Sorry, reading of blood sugar, glucometer. By the way, in the examination, you can check for the finger mark for the blood sugar, and this is for the diabetes. Yes, you can ask him. I offer to do bedside glucometer. You can say that to the examiner like this. He will know that you are searching for diabetes. It's a matter of how to show and to act in front of the examiner. Maybe the patient is surrogate, he doesn't have anything, but you will be more clever than the usual by showing the examiner, I'm doing all these things, even the patient is intact and healthy one. Okay? Yeah, Dr. Awad, if you have a question, so thank you for the question, Dr. Mahmoud. And thank you also for
Regard,
adding the cataract, yeah, to our examination. Yes, Dr. Awad.
yes, regarding this speech language, there is no any dysphagia or murmur.
Difficult of swallowing.
So, yes. So
Mhm.
we will not mention صح in the clinical judgment team.
Okay, let's say you will not mention. And what if you mention? You are safe, doctor, and you want to assess his swallow. What the problem? Maybe he's still having some difficulty to the liquid, and it's not still manifested as severe or as moderate or whatever. Whatever the degree, you are not the one to diagnose it. And what the harm if you mention?
Yes, you are
And you
right.
can, yeah, no harm to mention. And you can add one sentence at the end according to the need. Yes, I will do this and this and this, and I will invite this people, this doctor, this specialty, according to his need. If he says why you mentioned it, you can say I said if the patient needs. So if he doesn't need, I will not. We will not call him. But if you consider him. Why? Because the weakness is you don't know the way of the weakness. Maybe he's in advanced stage or he will be in advanced stage, but they will follow him one day. Those patients will be progressive in their manifestation. And one important thing in non-pharmacological counseling and genetic counseling team for the future uh, kids to select and to screen before having marriage on before having kids. This is also one of the welfare point because this disease is preventable one, not curable one. Okay? Yes. Hypogonadism, so
Okay,
ask
thank
for
you.
fertility.
Thank
Yeah.
you.
Any, thank you, Dr. Awatif. Thank you, Dr. Mahmoud. Thank you, Dr. Awatif, for two cases, new diagnosis. Yes.
Can I say yes? I have some comments. First of all, cataract is one of the cause, and also with cataract we'll see that the loss of the red reflex with ophthalmoscopy, I think.
Yes. Excellent. Yes.
Other thing is this myotonia dystrophica. Also, the echo you said it's important because sometimes it cause mitral valve. The patient will have mitral valve prolapse with myotonia dystrophy.
Mhm.
Other things, when the doctor say, sorry to ask you some question, do you smoke? No, don't
Mhm.
say sorry. You can say, I just want to ask you some question regarding your lifestyle. Do you smoke? Do you drink alcohol? Don't say
Yes.
sorry in smoking. Tell him, I want to ask a question about lifestyle. Do you work? Do you smoke? What do you do for living?
Yes.
We don't need to say sorry for this question.
Agree.
Yes, the other things in the differential, we should put the hypo, the hypo, the periodic hypokalemic paralysis. Hyperkalemic periodic paralysis is one of the differential because hyperkalemia it's come as a weakness on episodes, and also it is if the patient will have myopathy is one of the differential of myopathy. The hyperkalemic periodic paralysis is one
But
also of the differential.
Dr. Sarah, the complaint is double vision, not the weakness. If the weakness, I agree, but this is double vision
But he
case.
said that he has a weakness.
Yes, yes, I agree. Yeah, there is weakness.
Yes, it is one of the differential. I think we can add it as one of the complaint, which is the weakness. We can add the
No, no,
hyper.
no. The complaint was double vision, Dr. Sarah,
Ah, okay, okay.
not
But
weakness. Yeah,
okay, this is my comment.
yeah, yeah. Thank you so much. Yes,
Okay.
appreciated, Dr. Sarah. Your comment, yes, was targeted regarding the cataract red reflex while, yes, doing the examination, eye examination, and
Yes,
echo also. The purpose of echo not only to diagnose something you suspect, you might have some association which you don't know about, and the echo will find it. Even
yes,
accidental finding, yeah, maybe valvular disease, maybe something like precordial effusion. So it's not to diagnose rather than or it's like screening for other complication. Yes, you can say like that. So it's not a matter of I want to do examination of the echo to screen for something you suspect. No, it's to screen for other association, to screen for complication, and it's non-invasive test. Nothing to do or no harm if you do it.
yes. And also we can do muscle biopsy for which can show a feature of
Yeah,
myopathy.
very important. CK, yes, we missed the CK in this patient. You're right.
And muscle biopsy,
CK and muscle biopsy, one of the specific test in this patient. Sorry, we didn't mention it. Thank you, Dr. Sarah, for reminding.
but I
Yeah,
have
this
a
is one.
question regarding
Yeah,
the
yeah,
if
sure.
you said the conduction study, which type of conduction of study? I didn't get it. And what we will
I
find?
think no, it's not nerve conduction. It will be EMG.
EMG.
It's a muscle problem, not nerve problem.
And the EMG, it will show?
It will show the disease. I don't know. We can ask Dr. Rabia.
Okay,
We are
ma'am.
not okay.
Yes,
I
it's very
don't.
detailed question, Yani. Tamam, it
Yes,
will just show
yeah,
you
Dr.
diver
Rabia.
bomb's appearance. Tamam, Yani, it will give you some voice like a diver bomb, like a bomb voice. So it will, but it's not necessary for you guys. Yani, they're not going to ask you in detail. The
Yes,
EMG is
yes.
conclusive for myotonic dystrophy, but this is more than enough. Okay, NCS will be normal.
Mhm.
Okay,
Yeah.
okay.
Yes, yes. Thank you, Dr. Sarah, for the
I would
question.
like to comment on differential diagnosis, Tamam.
Yes, sure, Dr. Rabia. Yes, tell
Yeah,
us.
a ptosis with diplopia, and this weakness is distal weakness, okay? So, as
Yes.
Dr. Sara said, hypokalemic, hyperkalemic, if you are thinking even, it's called proximal myopathies, okay? So, it will
Hmm.
not come as differentials of distal myopathy, okay? Number one. And number two, a ptosis and ophthalmoplegia. One of the top differentials, myasthenia, okay? Then myotonic dystrophy, and then other muscular dystrophies in the form of oculopharyngeal muscular dystrophy or mitochondrial myopathy in the form of Kearns-Sayre syndromes. Okay. I disagree with putting multiple sclerosis because which multiple sclerosis causes bilateral ptosis and bilateral diplopia. Tamam.
Hmm.
It's very unlikely to put MS. MS cannot come with bilateral ptosis, okay? It could be bilateral third nerve palsy, but very less likely that MS can cause bilateral third nerve palsy, okay? So you cannot put
Hmm.
MS. And there is distal weakness, which multiple sclerosis can cause distal weakness. So it's highly unlikely. You have to put myopathy or neuromuscular junctions, okay? You cannot
Hmm.
put central causes like this, okay? So for me,
Yeah.
it's myasthenia, myotonic dystrophies, other muscular dystrophies in the form of oculopharyngeal muscular dystrophy. And the fourth one is Kearns-Sayre syndrome, which is one of the mitochondrial myopathies. You can put Graves' disease, everything, but Graves the same, it cannot come with ptosis, okay? And diplopia, especially you have to ask, diplopia in which direction? Right up is horizontal gaze or upward gaze, okay? Is in the right or
Mhm.
is in the left, okay? It's a very vague term. You are saying diplopia. Diplopia in which direction, right or left, horizontal or vertical, okay? So if it's horizontal, it's most likely due to third and sixth and muscular, tamam. If it's vertical, it's
Mhm.
usually due to fourth nerve palsy, okay? And either
Mhm.
midbrain involvement, okay? So it's very important to ask the direction of the gaze palsy or the direction of the diplopia.
Yes. So this question by examining the patient or by asking the patient?
By asking, because patient will tell
Yeah,
you very clear, when I see to my right, I have diplopia. Or when I see to my left, I have diplopia. Or either I see to right
excellent,
and left, it's all diplopic. He will tell you by
excellent.
himself very easily.
Yeah, yeah. Okay. Clear explanation. Thank you, Dr. Rabia. So let's repeat the definition after Dr. Rabia comments as neurologist. We will start by myotonia dystrophica, which is the case, myasthenia gravis, and uh, Kern-Sire, or before Kern-Sire, you can add. You
Yes.
said something.
Ocul. Yeah, it's oculopharyngeal. It's one of the muscular dystrophies,
Yeah,
this hereditary muscular
oculopharyngeal.
dystrophy.
Actually, I'm not familiar with this
Yeah,
disease, so
just
I
like Dr.
can't.
Bison, facioscapular, it's one of the same groups. Facioscapular, limb girdle,
Yeah.
my this is oculopharyngeal. It's in the same group. Autosomal dominant disorders, all of them.
Okay. Okay. And the fourth one, Kern-Sire, it's
Yeah,
also
cancer.
affecting affecting the eye along with weakness.
Yes.
Yes. Okay. Thank you, Dr. Rabia. Read the comment before ending. Waxing and waning muscle discharge in EMG. I will never remember this. I don't know what is that, Dr. Abdullah. Anyway, so we will have the features of the disease in the EMG. That's it. I will say like that. I don't know what's the character of the EMG or the finding or the showing. As Dr. Rabia said, it's so deep and so far to know because we are not neurologists. Anyway, if you know as the specialist in this uh, in this branch, you can say it. For me, I don't know them. Okay. Any other question? Any comments?
I have question about this, intellectual disability in patient with motor
Intellectual in
neuron.
this patient, I think
Yeah,
they are free. Yeah,
to be
they are
assessed or
free.
no?
No, intellectual. Some of them will have intellectual disability.
Yeah, we
They
have
have
to.
or they don't have.
No, they
They
have.
have. They
They
have.
They
have.
have.
Yeah, they
Yes.
Yeah.
have
Okay.
some. We have to do any mental test or no? Need any mental examination or no?
Okay, Dr. Rabia.
Yeah, they have to do IQ testing. It's not mini mental. Mini mental is for dementia, tamam. They have cognitive abnormalities, so there is some high IQ testing you have to do for it. But for us, it's not necessary as spaces, Bardo.
Yeah.
Tamam, yani we just have to do this. But this patient have
To
some
offer.
cognitive. Okay.
Yeah. But I
Yes,
think
thank
if the
you.
patient, yeah, if the patient having this problem, they will not bring the patient himself.
It will be very
The-
mild, Dr. Basim. It will be not like very major, okay? It will be very
Mhm.
mild cognitive declines, okay? So they will not they will not bring patients like this who cannot tell you about their disease.
Yes, yes, exactly. Yes, yes. This is my point also. Okay. Thank you for reminding Dr. Ryan. I think this question will clarify more the topic and explore some of the details maybe we are not familiar with. Dr. Hadil sent thyroid function test in the form is in form in test of investigation thyroid function as association. I don't think there is association with the thyroid in this patient. Anyway, I'm not sure to mention or no, but if someone knows about thyroid association, I don't think there is association
I think in
or to rule
myasthenia
out
gravis,
methania.
yes,
Okay, as a methania, yeah.
yes, in myasthenia,
Okay,
yes.
yes. I thought it's a complication to the disease. So you are screening for the differential. Yes, okay, you can put it. Yes, I agree now.
There is also some association which is called nodular thyroid enlargement, but I don't know the hormones will see that or it's high or not. But there is one with the association called nodular thyroid enlargement, but I don't know the thyroid hormone will be high or low. I don't know this.
Okay, but let's say these details, if you talk in the target, you will not reach to this details and this extent of questions. So just for refreshment, yes, we are talking, and but what we discuss or what we have discussed will be enough and more than enough. But if there is some topic or some more details, just to refresh us for the scientific point of view. This is for, yes, exactly. This is for the knowledge only, yes. Maybe you have examiner and you are unlucky, or you are lucky to have the question which we are discussing nowadays. Maybe he will ask you target question for this topic and you will answer him, and this question will be for the full mark. You will be lucky in this way. Okay. If no more comment, no more question.
I have question, Dr. Basil.
Yes, yes.
Internuclear ophthalmoplegia that caused by
Yeah.
MS can cause double vision also.
Yeah, it will. Yeah, it's double vision. It's double vision, and it, by the way,
Yes,
it will not be corrected by either covering or not covering the eye.
yes. That is why we can put here CMS as a differential, because it is the common cause of this internuclear ophthalmoplegia.
Yes, I agree as a complaint. So again, I will repeat this point. Sometimes you put in your paper differential, okay, and it will be for the complaint. Then after you collect the case, the finding, the history, the examination, some of your differential will not be fitting with the case. For example, for as Dr. Rabia said, the MS as the diplopia, yeah, there is diplopia, but no ptosis. Totally agree. No ptosis in MS, right? Because ptosis is something for the muscle, and the muscle is not the MS, not a disease of muscles. Ptosis or MS is a disease of CNS. So one of the CNS, second nerve, oculomotor, or sorry, optic nerve, but other nerve will not be affected. Even the diplopia in MS is not related to oculomotor or the fourth or the sixth. No, it's related to the medial meniscus, longitudinal fasciculus, which is something also CNS. So it's different now. We can't put it as differential for the only complaint. Sorry, it's for the complaint only, but for the whole case, no weakness in the MS, for example, no weakness. It will
Yes,
be
you are
like,
right.
yes, yeah. So it's only spasticity because of, again, pyramidal affliction. But the
So,
spastic might cause also weakness as spastic, I mean spastic muscles. You got it. But it's not peripheral nerve affection. It's CNS. So you can put it in your differential, and the examiner might tell you, show me your differential, and you show him that it was one of your differential. And you can mention it in the differential, and you will tell the examiner, but against MS. You will say, yes, there is possibility of MS, but against that. What against MS? You will tell him no weakness in the MS, unless the patient is spastic. Okay? This is the point. You can put, and you can just show him that you are also aware about what you are talking about, not just putting differential for wrong way. I got. I guess you got my point, and I hope
yes,
so.
yes, yes.
Yeah.
Thank you.
Okay. Thank you, Dr. Mahmoud. Thank you, Dr. Sarah, Dr. Rabia, Dr. Awatif, and Dr. Nadir. All shared question and explain also, Dr. Hadil, Dr. Abdullah. Thank you all. If no more question, we can. Yeah, thank you, Dr. Awatif. Nice cases. If no more comment, no question, I can end the record for tomorrow participation. Thank you all. See you tomorrow.